through it, then it's probably better than showing the slides, which might be a little bit more technical. Okay.
Okay. So I'm just going to start by introducing you then.
Okay.
Okay.
Very good. Mm-hmm.
All right. Dr. Jonathan Woodson leads Boston University's university-wide Institute for Health System Innovation and Policy. He teaches in the university's business school, medical school, and School of Public Health. He served as Assistant Secretary of Defense for Health Affairs in the U.S. Department of Defense from 2010 to 2016. His expertise is broad in the areas of business management, health, law, policy, and surgery. Please welcome Dr. Jonathan Woodson.
Well, thank you very much for having me this evening to talk about the issues of health and particularly innovation in health. And as we sit here now, some 90 to 100 days, is what opportunities exist for improving our health system or thinking about it differently as we go forward. And I think that's really important to understand what, in fact, this current COVID crisis has exposed as vulnerabilities in our health system, and then use relative to how we can develop a new pathway forward to serve all of America better. So with that, I just want to go and discuss a few concepts that really are important to think about how we might improve the healthcare of the nation. So one of the things that has happened over decades of improving technology in healthcare is that we've come to a place where we've focused more about treatment of established disease. And as a result, we've not spent enough time in our healthcare system focusing on the issue of producing better population health and what that means to prevent disease and connect with communities. One of the things that the COVID crisis has clearly shown is that there are these enormous health disparities that when you get a crisis or an epidemic like COVID, how different populations are affected differently. And I'm sure everybody's aware of the headline news about the disproportionate effects on minority populations and to some extent rural populations, but particularly people of color. And this, of course, represents a large set of issues that are in play that adversely affect the health of these populations. And we call this the nexus between health, medicine, and society. But going forward, it's clear that we've got to have a more integrated plan to, in fact, address these health disparities and provide access to care for a larger distribution of our population. One of the things that I am fond of quoting is a quote from Herophilus, a physician who actually operated in ancient Greek from 325 to 255 BC, but he was attributed with saying that when health is absent, wisdom cannot reveal itself, art cannot manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. And if you think about this quote, really that's true when you don't address the issue of population health, because it means you don't have healthy citizens that can be productive and take jobs, and therefore the institutions of society can't be strong. You can't have a military if, in fact, you can't address disease. And one of the things that we had to deal with, certainly when we were at the Department of Defense, is the growing obesity problem in the United States that really reduces the number of individuals, both men and women, that can serve in the armed forces. And today, of course, with the COVID crisis, we realize that obesity is one of those risk factors that makes getting COVID a much more serious problem and create the potential for more complications. So we've got to address this issue as a nationwide set of issues. going forward and be able to develop a better population health-focused health system. Now, the issue is, of course, that we have to try and define what we want out of a system. And clearly, we want a system that is effective, meaning that we use evidence-based therapies leading to the best outcomes, that in fact, we have an efficient system which limits waste both in human resources and financial resources, that we are focused on the patient, the individual patient, in a precision way, because everybody's genomics and proteomics are different. And as a result, drugs that may work for me may not work for you. And we need to make sure that we're mindful of that as we apply therapies to patients, individual patients that have been based upon broader studies. We need to make sure that it's equitable. And this is, of course, shown to be a problem in our system through the COVID crisis, which is that not everybody who needs care can get to it, and not everybody has the same response, and there's an overburden of disease and negative outcomes in certain populations. So the system has clearly got to be equitable. We also want a system that is high performing and learning, which means that it achieves the results that it desires to get. And more importantly, we learn continuously from the data that's generated. So if you look at the COVID situation currently, we had to learn through our experience with this disease, not only on a worldwide public health kind of basis, but on an individual disease response basis, and understanding some of the new kinds of problems that this infection occurred in different populations. But once we learn that, we've got to apply that new knowledge as rapidly as possible to improve the care, improve the outcomes of every patient that we treat in the system. We want it to be connected, and in today's world, that means that we've got to have a digital strategy for leveraging digital technologies and connecting particularly the home with healthcare, because that's where, in fact, much care in the future ought to be delivered. More importantly, I think if we do that well, we can address some of the social determinants of health more specifically, or this nexus between health, medicine, and society. Now, I think for the audience, we need to understand a couple of things, that this is not necessarily pie in the sky, that we really, with new aggressive leadership and a new focus, can achieve better outcomes and a better connected system of healthcare. We have traditionally spent a lot of money in terms of our American system, over $3 trillion. But not all of that is used wisely. And so it breaks one of the tenets of the kind of system we're trying to develop in terms of an efficient system, meaning that we waste up to a third, some even say a half of what we spend on healthcare, because we're either providing care that is ineffective, or care in the wrong amounts at the wrong time, perhaps to the wrong patients even. So if we are able to create that learning system, we can apply the right care to the right patients at the right time, achieve better outcomes at reduced cost. And there are many statistics that have, in fact, been assigned in terms of evaluating health systems. And it's important to note that in many of these metrics, we rank very low in terms of world systems, in terms of our outcomes. So in many cases, we rank 37th in terms of the world outcomes on a group of metrics that are measured periodically. But more importantly, we have folks who are uninsured or underinsured, and this is going to be a particular problem after COVID crisis, as individuals have lost jobs, and in fact will call into question our employer-based system of insurance, as employers as they try and recoup from this crisis and lost productivity, are going to be asking how much can we afford to continue to have employer-based insurance, or should we, in fact, move to another kind of system with universal coverage that develops a different strategy for insuring our patients. That almost surely will be a question going forward, particularly since we've seen in recent years a progressive sort of trend to move more of the burden of paying for health insurance onto employees, but it still presents a burden for employers as they compete globally and have to pay higher prices for insurance in this country. So these are all issues that are going to drive change, but through the COVID crisis have been highlighted to new degrees. So just take a step back, of course, every system around the world pre-COVID has been trying to create greater access to care for populations, improve the quality of care, and create this financial sustainability, as well as human resource sustainability. So we're fortunate in this country where we do turn out large numbers of doctors, although as we subspecialize in medicine, the numbers of doctors available are not as great as one would think because of the subspecialization. But in other countries, it's really a problem to even, from a human resource or personnel point of view, to turn out the number of professionals. So these three factors are issues that every country in the world are dealing with in some form or fashion, that is trying to create access, improve quality, and create financial and human resource sustainability. In this country, of course, we've gotten to this situation, if you will, in terms of our health system, because many of the different components of our health system were not designed for the same aim. Many of the components were grown up as cottage industries, and as a result have different parameters applied to them in terms of how they operate successfully, in terms of either profit motives or service motives. In fact, in the 20th century, physicians were a big part of the problem because they were really operating more as a guild rather than a profession. They tried to preserve their primacy in terms of health system delivery and optimize income. And, you know, on the one hand, that is what all populations and professions and organizations do. But on the other hand, it doesn't serve very well in terms of developing an integrated system that addresses optimally populations in their health. And the same thing can be said of hospitals, insurance groups as well. So it's not one group, but it's all of the stakeholders that have grown up separately, sort of developing their own approach to optimize their part of the business. And as a result, today, we have a system which is not aligned. Many of the components are not aligned. So the issues of pharma, the issues of physicians, the issues of hospitals, the issues even of the government and the types of insurance plans it supports are not all aligned to produce the optimal system. And not to go into too much detail, but the issue is that this creates a complicated situation of trying to improve the system, because it's really a Gordian knot of historical, economic, law, regulation, politics, culture, technological, and professional issues that have grown up with different outcomes and aims and parameters of success in mind that need to be disentangled in order for us to get to where we need to go. But this brings us to the opportunity right now in terms of the issue of the COVID crisis, I used to say when I was in government, never let a good crisis go unused. And I think that is very true of this present situation. As we are making our way through the COVID crisis, we see the opportunities to disabuse ourselves of normal practices and see the opportunities for innovation. So, for example, telemedicine, which had been struggling to find its way into the healthcare strategy, has just taken off during the COVID crisis. Why? Because the crisis has created an opportunity for people to see things differently, to relax regulation, to provide economic and financial incentives for providing the service. So, for example, if you look at an institution like the Cleveland Clinic, prior to the COVID crisis, they were actually performing about 3,400 or 3,500 telehealth visits a month, and a comparative month in the month of April of this year, they performed over 200,000. Because it was an opportunity to expand this, there was a need to reach out to its patients in the midst of the COVID crisis, which prevented the normal, quote unquote, normal way of delivering care, which was to have each and every patient come to the hospital or the brick and mortar establishments to receive care. And as this kind of strategy has changed, of course, it's given an opportunity to focus on the patient in a different way. So it produces a lot of evidence that there's an ease of scheduling, and you can actually avoid long wait times. You can provide tailored communication for patients, and this all becomes important. Going forward, however, it will be really important to improve the accessibility to medical records, particularly when you're working across health systems and create data interoperability. So there are a lot of issues yet to be solved, but the current crisis has opened up the opportunity to allow people to think differently about the value proposition of telemedicine. And as a result, it's my prediction that this will now become a permanent part of our strategy for providing access to care and improving healthcare and the connectivity of healthcare, particularly with communities and the home. Just moving along, again, the issue is that our current system was never designed as a system, although we rapidly advanced science and technology. We've tried to deal with that in medicine by increasing subspecialization, which on the one hand has created a great deal of expertise, but on the other hand has created major chasms between specialists and major problems in terms of handoff of patients between specialists. And so we need to rethink how, in fact, we would design a system, particularly in today's age. So at our institute, the Institute for Health Systems Innovation, for Health System Innovation and Policy, we think about innovating in 5 major domains. The first domain is that of emerging health and biotechnologies that can advance care, but also advance the connectedness of care. And then we think about how to so that they're more integrated and interoperable in terms of the services they provide and handoffs between providers so that you can optimize care. Also the communication, obviously, with patients and the education of patients and communities. And then the third parameter is what kind of new leadership do you need to lead and innovate in health in today's world? understanding that it is complex and there are a lot of codependencies. The fourth is this rather wicked yet amazing basket of digital technologies that are emerging that could support the delivery and advancement of healthcare going forward. But in fact, it hasn't been utilized. So in healthcare, as an industry, we have been a slow adopter of technology and particularly digital strategies to improve our industry, unlike other industries that have robust digital strategies. Certainly, if you look at Amazon and Google, clearly innovators in the space of digital technologies. Groups like Amazon, organizations like Amazon, have totally disrupted retail, and in fact, coming out of the COVID crisis, they're likely to be even more disruptive. And now, of course, they've migrated into healthcare, so that represents an interesting opportunity. It may be frightening for some of the traditionalists in healthcare, but it represents an interesting opportunity, particularly since we have been presented with a lot of challenges in healthcare in terms of access during the COVID crisis. So there are many opportunities that we can actually see going forward, coming out of these events. Now, one of the issues that we're going to have to address is the financing of healthcare. This is probably going to be one of the biggest disruptions and issues we're going to have to rethink going forward. So I mentioned at the outset of this discussion that number one, there have been cohorts of American society, particularly minorities, that have been disproportionately affected by the virus. And this is a result of many issues that represent the nexus of health, medicine, and society. But the issue also is that even well-to-do middle-class individuals, because of the issue of the way industries and organizations are going to change post-COVID, are going to lose jobs. And in this country, we have an employer-based system of health insurance. That is, when you go and work for a company, they pay a part of your insurance. Usually it's a 2/3, 1/3 proposition, and the employee pays the remaining. If you don't have a job, that becomes a problem. And when you're looking at 40 million jobs lost in this COVID crisis, 40% of which some would predict are not going to come back, you are going to have a substantial portion of the population who is going to be uninsured or underinsured coming out. And we're going to have to grapple with this as a society, because remember, in my opening statement about Herophilus, we can only have a strong society if we have a healthy society. So the issue is how are we going to pay for this? There have been some studies done that suggest that, in fact, if you look and analyze how much we spend in terms of taxpayer-supported insurance, we spend more than most other industrialized nations in the world. But the issue is we don't get universal health care out of it. We don't get universal insurance out of it. So coming out of this crisis, we're going to have to rethink about how we spend those dollars and what we get for it. And I think there's going to be a growing demand from the population to fix this problem, to create greater insurability. And I think what we're going to probably see is a proposal, particularly from the Democratic side, to expand the public health option going forward. At the very least, what we will see, because people will be out of jobs, is greater enrollment in Medicaid. So that's going to be clearly, one expansion that's going to occur de facto, just because more people will qualify. But we shouldn't look at it that way. We should look at it from the point of view of how do we create a public option for insurance that will help fill the gap. Ultimately, whether or not an employer-based insurance program serves the needs of this country long term, again, because it makes our industries less competitive on a global basis, but also it will look like a non-sustainable proposition, again, coming out of COVID, where companies are trying to reestablish themselves, develop further investment income, meaning have the ability to generate profits to reinvest in their businesses at a time when healthcare costs continue to accelerate. In today's world, if I can shift gears a little bit, one of the big issues that are going to challenge us, and we need to take advantage of coming out of the COVID crisis, is the digital world. Now, as I mentioned before, many industries have already developed digital strategies, or more or less invested in their digital futures. We like to say that CEOs of companies, and particularly CEOs of healthcare companies and hospitals and systems, need to think about what their digital strategy is. We've used data, of course, over decades now to improve biotech and health systems and population health to a small degree. But much of this has been incremental. Very little of it has been really progressive. Some of it has been adaptive, such as the requirements for using data to do quality improvement projects in hospitals. But the real issue is, how do we use data, and what might be forced on us in terms of data and digital technologies that might be disruptive in terms of the fundamental ways we think about delivering healthcare. We know that there are emerging disruptive technologies, digital technologies, that relate to synthetic biology and nanotechnology, digital medicine, genomics and proteomics, and manufacturing, such as 3D scanning and 3D printing, that are increasingly becoming part of what we do in medicine, and certainly other industries when you think about 3D printing as well. But these kinds of technologies fundamentally will change the way we address the diagnostic and treatment of individuals. This is where really precision medicine lies, because again, your genomics and proteomics are different than mine, which may dictate how you respond to certain drugs or what therapies might be important for you in whatever problem you're having, versus the problem that I might manifest. So these are becoming really important technologies that are emerging, going to force, again, a digital strategy. We also, of course, are involved with the development of new biomarkers that will predict disease, that will monitor for disease, that will allow advanced therapeutics in real time. One of which we have today, of course, in terms of diabetes and glucose monitoring on an ongoing basis, that wasn't around a decade and a half ago, which allows for better monitoring of diabetes and blood sugar, and more precise administration of insulin to prevent complications. But beyond that, the issue of biomarkers is really an exploding field. And just think about some of the technologies that might be available in the not too distant future, where you can use certain biomarkers, or even what we call tattoo biomarkers, to identify when someone has COVID disease. How that would change our public health approach. But we can use a number of biomarkers to define our approach to diagnosis and the treatment of diseases. And this is on the horizon, some of which is even here today. But how do we incorporate that really into our strategy for delivery of healthcare? We really, as an American healthcare system, haven't thought holistically about these emerging technologies and how we incorporate them in, how we're going to pay for them. And as a result, we've got to think about a number of reforms. Just considering a couple of other disruptive technologies on the horizon, we have the issue of virtual reality and augmented reality, and where might this play in terms of patient education, workforce development. I think this is going to be very important in a very important strategy as we look to train our healthcare professionals, as well as educate our patient. Cognitive computing is going to be very important, particularly as we get more experience with artificial intelligence and data analytics. So in the Institute, we have a conceptual framework in talking about developing a digital strategy for leaders, which we say has to accomplish the 3 A's. The first A is that we need to automate as many processes as possible, because if you think about, particularly in medicine, the amount of new knowledge that's generated, in order to be efficient, we've got to automate a lot of that process, because no one individual can process all the information for all the patients they're going to have to deal with to get to the optimal results. We've got to augment and amplify their capacity to deliver care through man-machine interface, not only on an individual level, but on an organizational-wide level. So, you know, when I went to medical school, there probably were about 250 to maybe 500 drugs that I really needed to know in order to treat patients across a wide spectrum of disease. And I could master those. Today's world, there are thousands of drugs, and it's changing all the time. And then again, if you add the other issues that I talked about before, genomics and proteomics, how individuals might respond, you can't master that amount of knowledge and keep it between your 2 ears and apply it in an effective way on any day when you're distracted by other issues, unless you've got a computer-based system, or what we call man-machine interface, that helps you do the job better. And so we got to look to enhance those attributes in our system. And these are what we call I like to term, are the instruments that we will have to learn to fly by. We need to develop more of these instruments. Other disruptive technologies that are going to change how we do business include robotics. We talked about telemedicine, but also blockchain that might, in fact, allow us to transfer data more effectively with greater privacy, because you have trusted ledgers and trusted business rules. Why in the 21st century should information be so segmented into different systems so that there's no interoperability is unknown to me, except for the fact that, again, we've grown up with our systems where we're highly stovepiped into separate systems. Electronic health records have been designed to be customized for individual hospitals and don't crosstalk with each other. But in the future, we're going to have to move into a place where there's interoperability of data, patient-controlled data that will allow us to provide services across systems at will. One of the issues in terms of data has been that for years, many of the systems were designed on a system of actually information great business model to sell more of whatever product you were, or whatever information system you were trying to sell. In the future, the competitive edge is going to be to remove that information block. One of the things we learned in the COVID crisis, as we had many of these COVID centers being set up, and we were trying to deal with the issue of the logistics of PPE and other types of equipment, ventilators, is we had no way of knowing what individual hospitals or systems needed, because we didn't have the data systems that crosstalked as easily, let alone the issue of patient flow. One of the problems we faced early on, of course, is this issue of capacity. There was a great worry or concern about running out of capacity. The truth of the matter is we probably had enough capacity, but we didn't know where that capacity was. There were certainly some hotspots like in New York that had reached or maybe exceeded the capacity, but even within that geographic area, the question is, where was the capacity? And not having information systems that were interoperable, that poses a problem. And going forward, we're going to have to address that. So, as we move along here, the digital disruption in healthcare is what we've termed the digital health matrix. And it's really about every organization thinking about their future in the digital age. Organizations must understand and they must break free of their traditional modes of doing business. And this is clearly true in healthcare. Every industry must become digital or have that digital strategy. Incumbents must think about how they compete and collaborate within the digital age with groups that traditionally haven't been in, and how to use these platforms for better understanding of what individual customers or patients need, and understanding what capabilities, capacities that they need to build. And again, organizations like Amazon and Google have that built into their DNA, that innovation and the understanding of platforms. So as a result, even before COVID, we started seeing emerging of healthcare. We have seen the advancement of big data analytics, although not applied in a way that I think it's been most useful in healthcare. But again, because of the real need to know where there are outbreaks and which patient populations are being more affected, I think we're going to see the advancement of big data analytics. So if you think about the COVID crisis, it's very interesting. What we did was we applied a blunt cudgel to the world, and certainly to the society. We just shut everything down, and to some extent applied 19th or early 20th century rules in order to flatten the curve. And that was done of necessity. The issue is that with big data analytics, we probably could have allowed some segments of our society to function more normally, even as we went through this crisis. What do I mean by that? Well, for example, first of all, when we discovered that there was a problem in China, there were actually databases that picked up on it fairly early, despite what you think or may not think about the openness of the Chinese to deliver information to the rest of the world. But importantly, that combined with, let's say, data from the airlines about what were going to be the likely contact points, contact cities, in which folks from China would actually travel to, could have predicted and really did predict where the next outbreaks were. So you may have seen a segment on 60 Minutes. There was a company that actually did the analytics around that and were quite accurate in predicting where the next outbreaks were and predicting where the outbreaks occurred in the United States. In the future, applying those analytics would allow us to put in preventive measures much sooner and contain and allow segments of society to operate. But more importantly, the further development of data and analytics would allow us to understand which parts of the population were going to be at most risk. So in viewing the data from the current COVID crisis, we see that the majority of admissions and bad outcomes, of course, were in patients 70 years of age and older. We could have immediately zoomed in on protective measures for those individuals, particularly those in nursing homes or assisted living facilities, and provided that dome, if you will, of protection, and probably reduced our negative outcomes by half, if not have produced marked reductions in the number of people who were infected. So data analytics really are going to be important in the future, as well as treating more routine diseases and chronic diseases as well. Part of what we're going to see also is new partnerships. So prior to COVID, of course, we saw new models of healthcare with CVS and Aetna joining, and part of their issue there was that they were combining the analytic capability of Aetna and the data that Aetna had with the retail platforms that CVS had, and trying to turn CVS into health destinations. So no longer would it be just a drugstore where you could go in and browse for items of interest, but with the use of pharmacists there and nurse practitioners using cognitive computing to assist those professionals in delivering more advanced levels of care, you now had a health destination that could serve communities. And this becomes very important in rural areas or more rural areas where they may not have a great deal of health practitioners. And it becomes important in terms of developing new models to increase access to care in these areas. And by the way, of course, the rural areas have been more affected by COVID, as many rural hospitals are threatened. Some 25% probably are extraordinarily affected by COVID. 79% of rural hospitals had, revenue on hand or cash on hand to sustain operations for only 33 days. And so if you cut into elective procedures and elective visits, you can see how they would threaten bankruptcy very, very quickly. So we need to think about these new partnerships in healthcare going forward as a strategy for innovating our healthcare. And we need to think about how we connect all of these pieces. So the traditional health systems, these new models of healthcare. When I give talks on the issue of new models of healthcare, a group of very traditionally based CEOs, and I asked them, do you think CVS Aetna model is a new competitor, or is it are they a new partnership? And at first they're wary about these new partnerships as being competitive, but in fact, in an integrated system, they may actually be leveraged to provide some of the community-based care, perhaps at lower price, and provide greater access to care. But we need to be able to entertain these, but more importantly, incorporate it as part of the digital strategy going forward. So that's very important in thinking differently. I want to talk a little bit about the issue of other aspects of how we need to change and how we should see things differently. One of which is that which we define and has been defined as the convergence of digital and genomic technologies with healthcare, living, and society to enhance the efficiency of healthcare delivery and make medicine more personalized. Now, that's a mouthful, obviously, but what it says really is that we've got to understand who people are, what the genetic makeup is, what they do as normal habits and culture and culturally to understand how, in fact, to more precisely enhance their abilities to live long and healthy lives. And this is, by definition, a multidisciplinary approach. In some ways, you've got to engage patients and customers. You've got to be able to optimize clinical care and the administrative process. It is clearly a precise way of delivering medicine or delivering care, which can be supported by wearable, again, biosensors, mHealth or mobile health devices and apps, and again, big data and analytics. So let's take an example of what we're talking about in this brave new world. If I, as a doctor, have a patient with congestive heart failure, and I know that weight gain is a sign that they may be taking on more fluid or their heart condition may be worsening, normally these patients would come in to see me when they're short of breath or show up in the emergency room, and at that time you would try and address the problems. But that's after the horse has been gotten out of the barn. In the brave new world of digital health, what we would see is a patient at home stepping on a digital scale once or twice a day, weighing themselves. And if I were to receive that information, particularly if it went through some analytic algorithm that understood some of the other issues relative to the patient, and we saw a 2-pound weight gain in a relatively short period of time, let's say 12 to 24 hours, we know that that patient is likely to be developing worsening heart failure and will show up in the emergency room. But we could probably preempt that by having automated systems that would increase the amount of diuretic that they're taking, that is a water pill that allows them to excrete more water, and then prevent that emission to the hospital. We can combine these technologies, let's say, with the medical Alexa for the home that Amazon is developing, which actually can give medication instruction. They're actually developing a module for giving medication instruction. And that's what the brave new world really looks like when we apply a digital strategy to our delivery of healthcare. Other components that we'll probably see coming in the not too distant future is that understanding that computers are better at image recognition than humans are. Combining both computers and humans, we can see how, in fact, we might be able to read X-rays better, particularly across time and space. Deliver services like dermatology, which are often in short supply in some areas across time and space. Deliver pathology services for diagnostic purposes and in terms of cancers across time and space, mammography, etc. These are all digitally based technologies that we can improve access to care. So, as I begin to sum up, the issue is that in the future, particularly coming out of COVID, it gives us an opportunity to look at new ways of designing systems that are connected, interoperable, and where we look at the home as the first and last line of delivering care, connected by the Internet of Medical Things going forward. The digital space is now considered the fourth space in healthcare, again, connecting other services, because remember, the issue of developing a comprehensive approach to healthcare in our society is addressing these issues of the nexus between health, medicine, and society. So the issue is we need to be talking about where people get food, where they're employed, where they live, work, and play, and some of the factors that are associated with more optimal health outcomes. We can monitor patients better in terms of, let's say, their progress with certain psychiatric disease like depression, and be able to intervene before a crisis happens. So the digital fourth space is really going to become very important. Part of what we do coming out of COVID, and as we develop a better digital strategy, is going to have to reflect in an adjustment of how we produce our workforce, because we've got to prepare them to work in a different age of medicine, but more importantly, apply their skills in a different way, and be able to enhance the ability of heretofore less well-trained individuals to upgrade their skills and provide greater capacity. We talked about the issue of cognitive computing, and how that might enhance the capabilities of any professional, but it can also enhance the ability of less well-trained medical workers to do the job in communities as well. So a digital strategy also it's important that it'll change our workforce development, and it's an important issue that we need to address going forward. So the last thing I will talk about here before I take questions is the issue of how do we get there? So one of the big issues coming out of the COVID crisis is going to be a discussion of effective leadership. Every day at noon, the governor of New York has a conference, and other leaders in individual states might have a conference. There used to be a 5 p.m. Meeting with, or I should say, press conference that the president used to have. And we've been able to effectively, as individual citizens, sort of gauge how effective these leaders are. Going forward, one of the things we're going to recognize that the effective leader will really help their organizations pivot and thrive in a new world, and understand the complexity of the problems. They're going to be able to create the enthusiasm for change, and they'll recognize this accelerated pace of change and the need for this change. They'll be able to assess the disruptive influences coming from outside the industry and embrace those as part of developing the solution set, and be able to create the teams of individuals that are eclectic, and will be able to develop more robust solution sets. So one of the problems always in solving complex problems is to surround yourself with people who think like you, those who are within the industry, and almost always that never works for developing comprehensive solutions to complex problems. You really do need people who do not think like you to come in and introduce new ideas to develop the solution set. Leaders are going to have to make the right strategic investments. So again, for all the money we've spent on electronic health records, we really haven't gotten much in terms of a robust digital strategy. As we look going forward, we're going to have to think about where we make those investments. And that's going to include in how do we cultivate new partnerships, and what are the right partnerships to cultivate going forward. And I talked already about the issue, we need to develop the workforce to be part of the solution. If we fail to do that, we will not advance our strategy for delivering healthcare as rapidly as we need to. So they're going to have to embrace what are considered the wicked problems in order to develop these comprehensive solutions. So I'm going to pause there. And if there are any questions, I'd be happy to answer those. That's kind of a broad view of how I see us utilizing the COVID crisis to catalyze innovation in the health space. I think you're on mute.
She is.
Okay. I have a question. With all of the, the digital space that you've talked about, how will privacy be protected?
Well, I think we can protect privacy, and that's why I brought up this concept of the blockchain and how we might use it. So I don't know when you've been to a bank last, but most people don't go to the bank and deposit their checks anymore. Banks do a lot of things nowadays, but that kind of routine interaction of moving money around is done in the digital space. And we trust it, believe it's secure. It's given us a lot of ability as individuals to do that. Well, that certainly can be done with health information. One of the reasons you can do it in the financial space is because you've got trusted business processes and trusted ledgers and verifiable security systems that allow you to do that. But much of that can be applied to the health space. And so one of the things that may seem radical, but really is very important, is in the future to give individuals, make individuals in charge of their own health data. So if you think about it, in the future world, if I need a dermatology consult, right, and there's a platform that says Dr. X at UCLA is available in the next 2 hours to see you, right? I should be able to have Dr. X at UCLA on the West Coast, I'm on the East Coast, pull down my data. I should be able to do a consultation with them through digital technologies. He can look at my lesion or whatever it might be, and I should be able to accomplish that at my convenience in a very secure environment. What it takes is effective leadership, I think, to integrate what is really available today into our health system. Right now, we're so siloed. We think that the protection is based upon what I can control in my individual system. And in fact, that enhances the vulnerability, because when a hacker gets into your system, all of your information is exposed at that point. So it takes a different mindset to apply technologies that are available, but we can achieve the privacy and the security concerns. We can address this privacy and security concerns that everyone has.
I have a question. How do you see alternative care as part of this solution or changes that are coming up?
So when you say alternative care, do you mean non-traditional medicine?
Mm-hmm.
Yeah. So it's interesting that I see that as becoming an increasingly important part of what happens. So if you look at the CVS health destination concept, they're really talking about yoga, mindfulness as being part of the therapies that they might offer. As part of the military health system, when I ran it, we actually invested in investigation of alternative methods, because treating post-traumatic stress opens itself for a lot of alternative kinds of therapies that might be very important in terms of allowing individuals with PTSD to cope and need and have more normal lives. It gets away from medication. So I think it plays an important part. The only issue that we need to do is make sure that those alternative methods are as rigorously studied for effectiveness as some of our drug treatments.
Right. Now, and getting back to what you had said earlier about effective leadership, how do you think it could happen that, all the data would be shared and investments would be made in a very effective way? And do you think that's the government's role, or do you think there's any way that the marketplace would do this?
Well, I think there is a role for the marketplace in conjunction with government. This gets to the broader issue of developing smart policy going forward. But the reason I brought up this issue about coming out of COVID and understanding the impact of how we're financing healthcare as being a prominent issue, particularly as jobs have been lost and companies are trying to reconstitute themselves and create the productivity, the financial productivity to reinvest in their organization. They're going to look at this drain called financing healthcare. And it's going to look differently than it did back in the 1940s when it was, when it was really coming of age, because we were in the World War II. Healthcare costs were really low at that time. And in order to get workers to work for a company, you provided them healthcare, but then it was only a few dollars a month to provide access to a GP or to provide access to a hospital. But if you fast forward to the 21st century, where healthcare is so expensive, it really becomes a drain on companies, particularly when they're competing globally. So coming out of the COVID crisis, I think it's going to shine a new light on that particular issue. And government combining with health advocates, combining with leaders in industry, should be looking at alternative ways to finance. As I said before, if you look at the actual numbers, in the United States, we have a greater proportion of tax finance healthcare than anywhere in the world. And the reason to look at it that way is that we tend to think that whoever writes the last check is the way we define tax supported to healthcare. So, of course, Medicaid and Medicare, we would say that's tax supported. But every municipal employee, state employee, federal employee, to include the military, really have tax supported healthcare, right? You pay taxes; those are government employees. And the government supplies the healthcare. The only problem is they supply it through a middle person, a middle organization, some health insurance company, which skims off some money, which as an administrative cost, of course, and that increases the cost to the government. The question is that if we had some universal vehicle, could we provide access to care for many more at a reduced cost? And particularly if we had a digital strategy for doing that, could we provide better access to care at reduced cost? So the whole issue of the future of healthcare requires reengineering. It requires realigning all of the subcomponents to align them better to produce the aim, which is a better healthcare that's effective, efficient, patient-centered, learning, and provides equity, obviously, in the health space.
What's the likelihood that you think that this would happen?
So again, we've been discussing this and dealing with this for decades. Mm-hmm. The issues have become more strained. The COVID crisis has exposed. It's a tough issue. There's no doubt about it. But this is again where effective leadership comes into play. It won't happen overnight, but we could really set in motion a series of re-engineering efforts and health policy that could get us there. And make it better for, again, just about everyone, from the individuals to companies to, again, the American society in terms of a healthier population, again, which is very important, again, to the overall productivity of this country. So it's tough business. The biggest issue right now, I think, for us is that people immediately see winners and losers in this, right? Okay. So if you, for example, insurance companies are many of them are publicly traded, right? They're in people's 401k. How do you provide a space perhaps for fewer insurance companies to continue to operate, but promote more universality of insurance that's not employer based? And so it's about a transfer of the monies that we're spending. The biggest example of this, of course, was Bernie Sanders' proposal, which was, just have everybody take Medicare. But the shift that would cause, if you tried to do that overnight, was just so tremendous that people couldn't wrap their heads around how to do that. Mm-hmm. But the issue is that if we think about incrementally how we begin to break down the silos, create a more integrated system, a better financing that reduces our costs, then we can get there. Now, to the point about never letting a crisis go unused, I think coming out of this with the national debt the way it is, we are going to have to think about some fundamental changes going forward. Be saddled with an enormous debt, and if we don't think about different ways of doing business that reduce costs, we won't have any discretionary money to do anything in terms of education or infrastructure or these other things. So some of it may be forced by the overall fiscal situation.
Which, it may not be so bad because, I can't imagine the pandemic not driving changes in our healthcare system. And yet I can imagine it.
Well, yes, you're right. I know what you're saying. A part of the issue is the enormity of the issues in play. Mm-hmm. And this is where effective leadership has got to come into to play and say, okay, wait a minute. We actually can do this if we break this up into manageable and understandable problems that we connect the solution set. Otherwise, people always think about winners and losers, basically, and creating the win-win space is really where I think effective leadership will needs to be. But coming out of this, if you think about the second and third order effects of this health problem, in terms of company viability, job loss, et cetera, we do need to be addressing re-engineering our health system in a more effective way.
Mm-hmm. Therese, do you have any other questions? Did anybody?
Do you see, an incentive for people to go into primary medicine again? I mean, with the cost structure being changed.
Sure. Yeah, so I think that's one of the aspects of medicine that we need to rethink. What I mean by that, I talked about workforce development. So when you think about the issue of delivering primary care, we have traditionally thought about it in terms of the number of primary care doctors. The truth of the matter is we'll never produce enough primary care doctors to deliver the primary care that the nation needs. But the issue is that we can produce enough of a primary care workforce to deliver the care that the nation needs. And this means nurse practitioners, physicians, assistants, and the like. And it may be that in a hierarchical structure, for the more complicated case, as they work in either teams or in associated groups with nurse practitioners and physicians assistants to deliver what could be up to 65% of primary care and chronic disease management. I mean, this is what CVS is after, right? In their model, right? They're going to use their pharmacists and they're going to use nurse practitioners to capture 60% of primary care in the community using cognitive computing assists to help them deliver, what hopefully is quality care, and that can be achieved. So the issue is about rethinking which professionals we use in which way, and how can we achieve the 3 A's, automation, augmentation, amplifying their capabilities through man-machine or cognitive computing interfaces, right? And this is very important for rural areas where they'll never be able to attract enough doctors there. But we can provide them certainly sophisticated care using other health professionals, particularly if they're connected to, university systems. So there are telehealth consultations and all these other things that can go on that to enhance the care and provide greater access to care.
I have a question that may be wildly simplistic, but you're talking about in the 1940s that healthcare costs were dollars, right? And a certain amount of that is due to inflation. But what do you think drove the cost up by so much?
Oh, it's very clear what drove the cost up. So in the 1940s, of course, World War II, wages were frozen, and again, we developed this employer-based structure because healthcare costs were relatively low. But in the 50s, after the war, and certainly into the 60s, the government made a conscious effort to invest in medical research and advancement of health technologies. NIH came on board, et cetera. So we have done very well with advancing the strategy of care for established diseases. And we get into certainly current day where we can cure hepatitis C. It'll just cost $100,000 per patient. Hepatitis C, right?
Yeah.
And so that's where the dollars, and of course, we've invested in healthcare infrastructure and technology and workforce, which is all very expensive. Personnel are very expensive as well. So that's where you get the increase in cost. The question is, does all of the care need to be delivered in these brick and mortar structures? Probably not. Should we be preventing the development of expensive diseases, expensive to treat diseases? Absolutely. And this is where a refocus on health rather than healthcare comes into play, and the issue of prevention of disease, the prevention of community-based services, this nexus of, as you say, addressing the social determinants of health, which I term the nexus between health, medicine, and society, becomes very important in our strategy for building a healthy population.
If you had one thing to say about what we should change right now, what would it be?
So the one thing we need is effective leadership. That is individuals who can imagine the future, imagine a better tomorrow, and then motivate people to work toward that common goal. Because otherwise, everyone is segmented, segregated into their own world, their own way of doing business historically, and the concept of winners and losers. And so we don't get to where we can imagine what might be a better state. So, this is part of the problem with the partisan approach to analyzing healthcare, is that they're all thinking about winners and losers and looking at it through their narrow ideologic parameters, rather than understanding that we probably can get to a better state and satisfy everyone's needs without there being the dramatic losers that prevents anybody from thinking about the better tomorrow, basically. That really is the problem. So it's not that one camp is right and one camp is wrong, is that you need to understand that healthcare embrace that complexity. You got to be willing to listen to and understand some of the nuanced issues that allow you to understand how you can re-engineer the system, and people can benefit. Yes, there'll be some industries that will change in focus. There's no doubt about it. But you don't get progress without that kind of evolution.
Therese, do you have anything else?
No.
This was wonderful.
Well, thanks. I hope it was helpful.
Amazingly
Very
helpful.
I feel better. I feel better already.
No, I mean, I think there are some great opportunities out there. Again, never let a good crisis go unused. So while we've got focus on healthcare, the issue is what kind of comprehensive re-engineering we should pursue as a society, because otherwise we're going to be looking at other financial issues come into play, as the federal budget provides, there's increased stress on the federal budget. Workforce issues are not addressed, so this is a real opportunity.
Yeah, it really is.
This is the Renaissance.
Mm-hmm. Yeah.
Right? Dr. Woodson, thank you so much.
Well, my pleasure. Again, I hope it was helpful.
Very helpful. Thank you.
All right. Take care now. Have a good night.
You too.
Thank you.